Hello and welcome everybody to another episode of Rapid Fire Review from Kurt's Notes. And today we will be going through the salivary gland. And in the salivary gland, we have numerous type of lesions, and the lesions that we will cover today are the inflammatory lesions. So before we begin, please like, share, and subscribe to this content. And let's begin. So as you know that before we start discussing any particular organ system, what we try to do is that we try to classify broadly the lesions into different categories, and then we try to go through these individual categories, right? So you do not have to become intimidated or frightened by this big chart that I have made over here. The reason that I have made this chart is that we have a broad schema in our mind. Whenever we are going through any particular salivary gland lesions, we can ask ourselves these questions based on these headings. Is it this type of lesion? Is it this type of lesion, right? So these are all our these categories or these classification, subclassification, or all our questions that we will have in our mind whenever we are looking at a salivary gland excision or a biopsy, right? So let's go through the individual headings, and then as we are doing the individual videos and the individual reviews, we will go through in detail the individual things. So the only questions that I want you to remember whenever you are looking at any salivary gland excision or biopsy is that your question number 1 would be, is it inflammatory? Your question number 2 would be, do the cells appear oncocytic? Your question number 3 would be, do the cells look basaloid? Number 4, do the cells look squamoid? Number 5, do the cells look to be originating from the stroma and have a spindle cell appearance? Number 6, do the cells appear to be high grade? Number 7, do the cells have a clear cell change? And if they are not getting classified into any of these categories, then can they be a part of some other tumors, right? So we are not going to the detail of all of these right now. We will just go to the detail of the inflammatory lesions. But for now, just remember that broadly, whenever I will look at a salivary gland tumor or a biopsy, the questions that I will have in my mind are: number 1, inflammatory question mark. Number 2, oncocytic. Is it oncocytic? Number 3, is it basaloid? Number 4, is it squamoid? Number 5, is it derived from the stroma, has a spindle cell appearance? Number 6, is it high grade? Number 7, is it clear cell? And number 8, if it's not falling into the other categories, is it one of the remaining miscellaneous lesions? Okay. So today is the question number 1. We will try to answer, is it inflammatory? And is it inflammatory? The further 3 questions that you can ask yourself are: number 1, does it have lymphoepithelial lesions? Because if it has lymphoepithelial lesions, it will be one of these two. It will either be the HIV salivary gland disease, or it will be the lymphoepithelial adenitis, right? So the first question, is it lymphoepithelial? Number 2, if it's not lymphoepithelial, then is it just a lymphocytic lesion? No epithelial component, just the lymphocytes are present. Then your differential diagnosis will be, is it IgG4 related adenitis, or is it Sjogren's syndrome? And we will look at the individual features in a while, right? And then our question number 3 would be, is it a cystic lesion? Because if it's a cystic lesion, it can either be a salivary duct cyst, or it can either be a lymphoepithelial cyst. Okay, so our 3 questions for if it is an inflammatory lesion are, is it a lymphoepithelial lesion? Because if it is, then it's either HIV salivary gland disease or lymphoepithelial cell adenitis. Question number 2, is it a lymphocytic lesion? Then it is either IgG4 related cell adenitis or Sjogren's syndrome. And question number 3, is it a cystic lesion? Then it's a salivary duct cyst or a lymphoepithelial cyst. Okay. So moving on to our salivary gland, let's review first what the normal salivary gland should look like, and then we will ask all these 3 questions and do all the 6 differential diagnoses of the inflammatory lesions. Okay, when I am looking at a normal salivary gland, what I should be trying to find is, number 1, the ducts, and these ducts can either be interlobar, intercalated, or striated, right? They can be present between the lobes, they can be intercalated, striated. Then the epithelium of these ducts should be cuboidal to columnar, and then they should be surrounded by these myoepithelial cell layer. These compressed cells present on the outside are the myoepithelial cells. So here we see another duct, right? And here we see another duct. They can be interlobar, intercalated, striated, surrounded by a single layer of cuboidal cells along with associated myoepithelial cells. Number 2, the thing that I'm trying to look for in a normal salivary gland are the acini. Here I look at this acinus, which looks like a bunch of grapes on cytology, right? It can be a serous acinus or can be a mucinous acinus, right? And the serous acini is specifically present in the parotid. They have zymogen granules, and they can also be mucus, which are present in sublingual glands, and these acini should also be surrounded by compressed myoepithelial cell layer on the outside. Okay, so the first thing I'm looking for are ducts. The second thing I'm looking for are acini. Number 3, I will look for fat. Here I can find the fat easily that is present, and this fat should specifically be present in the parotid. And number 4, what I am looking for are the lymph nodes, and the lymph nodes again, especially in the parotid, where the benign salivary glands can be present within the lymph nodes. So number 4 thing that I am looking for are the lymph nodes, right? Because the benign salivary glands can be present within the lymph node. Okay, well, number 1, ducts. Number 2, acini. Number 3, fat. And number 4, lymph nodes. And if we have symmetric enlargement of salivary gland with no discrete masses, I will consider sialadenosis, because this is a benign condition associated with systemic disorders like cirrhosis, malnutrition, and diabetes. So now let's move on to inflammatory lesion. Then if you remember our 3 questions, our question number 1 was, is it lymphoepithelial? Our question number 2 was, is it lymphocytic? And our question number 3 was, is it cystic? So question number 1, is it lymphoepithelial? Yes. Then my differential diagnosis will be either HIV salivary gland disease or lymphoepithelial sialadenitis, and let's go through them one by one. So the HIV salivary gland disease is basically seen with human immunodeficiency virus, of course. The age for it is that it is mostly present in younger men, and then it presents as a painless swelling or xerostomia, and we'll just go through the pathophysiology so we know why it is presenting as a painless swelling and why is it causing the dry mouth or the xerostomia. So what basically happens is that the pathophysiology is that HIV causes a persistent antigenic stimulation of the CD4 positive T and as the B cells. This causes the lymphoid follicles to undergo hyperplasia, and we already talked that the parotid gland can also be present within the lymphoid tissue, right? So since it's causing this like lymphoid hyperplasia of all the lymphoid areas of the body, lymphoid hyperplasia in the parotid is that it will cause the duct to become obstructed and the cystic structures will start forming, right? So the ducts of the parotid glands that we saw over here, because the surrounding lymphoid tissue is becoming so hyperplastic, this surrounding lymphoid tissue is going to obstruct these ducts, and when these ducts are going to become obstructed, then this obstruction of the ducts will lead to this cystic structures being formed. The cystic structures will be formed when the ducts are obstructed, and the fluid, the secretions, which are the mucinous or the serous secretions, they continue to become accumulated inside, right? So okay, here we see the characteristic histopathological findings, and that is why, by the way, that this duct is becoming compressed and the epithelium is also undergoing disintegration. Therefore the person is going to have a dry mouth, right? The ducts cannot produce the saliva that is necessary, or saliva or the secretions that are necessary to keep the mouth moist. And the swelling, of course, is because of the lymphoid hyperplasia, because the HIV is causing the lymphoid follicles to become hyperplastic. Okay, so the first finding, the histopathological finding we will look for when we are suspecting that the lymphoepithelial lesions are associated with HIV is, number 1, florid follicular hyperplasia. Here we can see the follicles are becoming hyperplastic, and specific features of this hyperplasia will be the mantle lymphocytes will be absent or attenuated. So the lymphoid follicles were so much hyperplastic that the mantle zone completely got, you can say, attenuated or erased. It disappears because it basically compresses the mantle zone because of the rapid hyperplasia. Then the germinal centers will also become disrupted. You will not find particular pinpoint clear germinal centers because again it's undergoing so much hyperplasia that the germinal centers also becoming lytic or disrupted. And then we will find, in addition to this, multinucleated giant cells. And why are they forming? Because HIV causes massive follicular dendritic cells proliferation, and these proliferation and activation, and these follicular dendritic cells ultimately fuse together to form multinucleated giant cells, right? And then this we will find out why there are lymphoepithelial lesions in a little while, but just remember for now that it is actually the follicular dendritic cells that are massively proliferating and fusing together that they are forming these multinucleated giant cells. So this was all our point number 1. And the histopathological features, will find lymphoid hyperplasia with the zone, mantle zone, completely disappearing or becoming thinned out because of compression by this hyperplastic lymphoid follicle. Then we will find that the germinal centers are also undergoing lysis or disruption because the architecture is disrupted because of the hyperplasia. And then we said we will find multinucleated giant cells which are basically formed by the fusion of the follicular dendritic cells, right? Next off, we have the second feature that we will look for are multiple squamous lined epithelial line cysts. And I already told you that why these epithelial line cysts are formed, because whenever there is duct obstruction, ultimately behind the duct that is obstructed, this ductal area tends to become cystic and dilated, right? So multiple squamous epithelial line cysts, and along with that we will find lymphoepithelial lesions. So what happens is that this hyperplastic lymphoid tissue invades and destroys the ductal epithelium. Therefore, there are islands of ductal epithelium that are trapped within dense lymphocytic infiltrate. This lymphoid hyperplasia is destroying it. So there will be areas where the epithelium will be trapped within the lymphoid tissue. So this is known as lymphoepithelial lesions. And besides this, we will find this number 2, these squamous epithelium lined cystic spaces caused due to duct obstruction by the lymphoid hyperplasia. And number 3, we will find these lymphoepithelial lesions caused due to epithelium destruction that is being trapped within the lymphocytes. Okay, so these were 3 findings for HIV salivary gland disease. Now, how do I differentiate this HIV salivary gland disease from lymphoepithelial silodenitis, since it's quite possible that I do not know the patient's history of HIV? So I have to differentiate these two on the basis of histology. So the pathophysiology of LESA, which is lymphoepithelial silodenitis, is that it is a chronic systemic lymphocytic autoimmune inflammation. Over there was no autoimmune component, there was an HIV infectious component in the HIV associated salivary gland disease. But here it's a chronic systemic lymphocytic autoimmune inflammation, right? And the hallmark findings for it will also be a lymphoepithelial lesion. But the thing is that with the lymphoepithelial lesions, there will be some florid lymphoid hyperplasia along with that as well. And the salivary gland ducts will be undergoing atrophy. But that much of the other things that you specifically find, and here Dr. Kurt has specifically highlighted it, that you will not find these multiple squamous lined cysts along with the florid follicular hyperplasia. There will be some follicular hyperplasia, but not as bad as that of HIV, because the HIV virus was causing the follicular stimulation. Therefore, the hyperplasia will be way more in HIV salivary gland disease versus lymphoepithelial silodenitis, and this hyperplasia will be forming way more squamous line cysts. Whereas squamous line cysts and this very florid follicular hyperplasia is not a characteristic feature of LESA, lymphoepithelial silodenitis. Rather, the characteristic feature for it will be lymphoepithelial lesions, right? And then the incidence is that normally occurs in women, and the location is the parotid. And they can have the histological findings for Sjogren's syndrome as well, the lymphocytic infiltrate we will see in a while. And then it can develop in the prognosis, it has a tendency to develop into a marked lymphoma. So we should be considered doing the IHC for the CD3, CD20, and then kappa lambda to confirm that this is not monotypic or is it monoclonal or is it a polyclonal inflammatory infiltrate, because once it starts becoming into monoclonal, then it's most likely a mild lymphoma. Okay, now this was all about our question number 1. Now moving on to question number 2, where we said, do I find predominant lymphocytic infiltrate, right? And then the differential diagnosis was IgG4 related sialadenitis and Sjogren's syndrome. So let's see what we will find in IgG4 related sialadenitis. Another name for it is Kirchner's tumor, and then the pathophysiology, it is a multi-organ autoimmune disorder that can form tumor-effective lesions, right? So it's a systemic disorder, it's multi-organ, it's also autoimmune, just like LESA, but it will form some tumor-effective lesions. And what we will find on histology is a dense lymphoplasmocytic infiltrate, as we can see over here in number 1. Then in number 2, we will find a storiform pattern of fibrosis, as we can see in number 2 over here. And number 3, we will find that the vessels will also start become obliterated and be involved by the lymphocytic infiltrate. So we will have obliterative phlebitis. So characteristic findings, not just a lymphocytic infiltrate, but with the lymphocytic infiltrate, if I find fibrosis and obliterative phlebitis, then it's most likely IgG4 related sialadenitis. And how do I confirm? I can find increased number of IgG4 positive plasma cells, and I'm supposed to see greater than 100 per single high power field, and I will find often increased serum IgG4 as well, right? And then the lobular architecture will still be preserved along with extensive fibrosis, inflammation or atrophy. So there is fibrosis, there is inflammation, there is atrophy going on, but still the lobular architecture with the lobules, the acini will still be somewhat preserved. And then I can also find florid follicular hyperplasia, but this florid follicular hyperplasia will also have the germinal centers, as we can see over here. The florid follicular hyperplasia has the germinal centers, and then there will be, the preserved lobular architecture and increased number of, we can find, if we stain these cells, they will be IgG4 positive plasma cells, increased number. And we said there is a cutoff, and we are supposed to see greater than 100 per single high power P, and we can do a serum IgG4 as well to confirm. So this was our IgG4 related sialadenitis. Now moving on to Sjogren's syndrome. Again, the pathophysiology is that it is a chronic autoimmune disease, just like IgG4 related sialadenitis, but over here there is lymphocytic infiltration of multiple exocrine glands. Over here there was a lymphoplasmocytic infiltrate with more IgG4, but here there is just lymphocytes, right? And the exocrine glands are more being involved, right? There was follicular hyperplasia over there in the other one, more storiform fibrosis, more obliterative phlebitis, but here we can find these exocrine glands, and these exocrine glands are now becoming infiltrated by this lymphocytic infiltrate. It can usually presents in, the incidence is that it happens in older women, and they basically present with involvement of the lacrimal gland and the salivary gland. So lacrimal gland will cause dry eyes, which is keratoconjunctivitis sicca, whereas the salivary gland involvement will cause dry mouth, which is known as xerostomia. And normally it's a clinical diagnosis. There we don't get a tissue biopsy, but we can get a tissue biopsy once they are indeterminate on the serology. But normally the serology is positive for autoantibodies, which are anti-Rho, which is also known as SSA, Sjogren's syndrome A, and anti-La, which is also known as Sjogren's syndrome B. So RO and then LA antibodies. And then the biopsy findings, on the biopsy we have to find a focus score, which means that we have to find a one particular focus, and this focus should have greater than 50 lymphocytes. And this focus score basically means that in a 4 millimeter square radius, what we have to find more than one particular focus. So one focus should have greater than 50, and then in 4 millimeter square I need to find greater than one focus. So 1 and 2 foci. If I find greater than one focus in a 4 millimeter square range, and then each focus has greater than 50 lymphocytes, so this focus 50 lymphocytes along with this focus 50 lymphocytes, and these foci are basically present within 4 millimeter square, then I'm going to call it that yes, this focus score basically indicates that this is Sjogren's syndrome. syndrome. Now moving on to the cystic lesions, which was our question number 3. Is it cystic? So in the cystic, we said there are two lesions, salivary duct cyst along with the lymphoepithelial cyst. And what is the pathophysiology of salivary duct cyst? This is a acquired cyst caused due to post-obstructive duct dilatation. So the duct got obstructed and then it got dilated, and now this acquired cyst is being formed, and it is most common in the salivary gland. And then what we will find a wall, number 1, that has fibrous tissue in it. Number 2, since it's a cyst, we will find some lining of either cuboidal, columnar or squamous epithelium. It can have goblet cells, it can have oncocytes, and then we will find associated inflammation and secretions. Okay, so 3 things: a wall made up of fibrous tissue, number 2, lining of cuboidal, columnar, squamous cells, goblet cells, oncocytes, or we can have associated inflammation or secretions. And then our differential diagnosis for it is another cyst, which is lymphoepithelial cyst. This was more like a simple cyst with some secretion inside, some inflammation, secretion inside, some lining outside, some fibrous tissue. And lymphoepithelial cyst, this is an uncommon acquired parotid cyst that is unilocular. This is its incidence. And then again we will have a fibrous capsule similar to a salivary duct cyst, but the lining here will be variable, can be squamous, can be cuboidal. But what differentiates it from the salivary duct cyst, right? It was just a simple cyst with lining and just secretions, but the characteristic feature which will differentiate from a lymphoepithelial cyst is that we will find abundant lymphoid tissue with prominent germinal centers, as we can see over here. So all the other things are similar, that is lining, that is like variable, can be squamous, can be cuboidal, and then there is a fibrous capsule. So all these things about lining a capsule were common, right? But this one, the salivary duct cyst, since it was formed by a duct, therefore it was supposed to have some sort of secretion and inflammations within it. Otherwise it just had this fibrous capsule wall as well as the epithelium. Similarly, lymphoepithelial cyst has this fibrous capsule wall and the epithelium in it. But the characteristic feature for lymphoepithelial are these lymphoid hyperplasia, abundant lymphoid tissue with these prominent germinal centers. And this is not related to HIV, it's just a lymphoepithelial cyst. It does not have that follicular hyperplasia of HIV. And remember that HIV did not have the germinal centers. There the germinal centers were being undergoing lysis, and there was squamous line cysts over there, but the florid follicular hyperplasia was forming these cysts, and the florid follicular hyperplasia did not have germinal centers. But here in the lymphoepithelial cyst, we do have a squamous lining, we do have fibrous tissue, but there are germinal centers that are present over here along with the lymphoid hyperplasia. So just before we end, we will do our quick recap of the questions that I will ask whenever I see a salivary gland lesion. Number 1, is it inflammatory? Number 2, is it oncocytic? Number 3, is it basaloid? Number 4, is it squamoid? Number 5, is it spindle cell or stromal? Number 6, is it high grade? Number 7, is it clear cell? Number 8, does it belong to any of the other categories? And in the inflammatory lesions, which is our category A, the questions I will ask is it lymphoepithelial? Then I will call it either an HFV related salivary gland disease, or I will call it lymphoepithelial adenitis. Or the second question will be, is it a lymphocytic? Then I can classify it as an IgG4 related adenitis or Sjogren syndrome. And question number 3, is it a cystic lesion? Then it can be a salivary duct cyst, or it can be a lymphoepithelial cyst. And this concludes our part 1 of salivary gland lesions, which were inflammatory lesions. If you like this content, please like, share, subscribe, and follow for more. Let me know in the comments how I should improve these videos, and I will see you in the next video. Till then, happy studying.